Hello everyone. I'll be continuing my discussion about pneumonia. So today the part 2. In this, the first thing to talk is atypical pneumonias. Well, what the basic concept about interstitial pneumonia? It's an acute interstitial pneumonia. It refers to inflammation of the interstitium of the lung. Definitely this the alveolus, this the alveolus, this the alveolus, and in between this space is the interstitium. So definitely when the inflammation will occur in the interstitium, we call as atypical. Because it means in a typical pneumonia, it is the alveolar, inside the alveoli, the problem of inflammation is there. When it is outside the alveolus or in the interstitium, then we use the term as atypical. So now, broadly, you understood the meaning of typical pneumonias and atypical pneumonias. So definitely when the interstitium involved, so primarily there will be involvement of the septal wall, alveolar wall, because it is the outside the alveolus, or in a most simplified way, outside the alveolus is atypical, inside the alveolus is typical pneumonias. Now, what are the causes of atypical pneumonia? Mycoplasma pneumonia is one of the most common causes of atypical pneumonias. Well, after that, viral pneumonias. Most of the viral pneumonia, they come in the category of atypical. A large list is there, like influenza is the most common in elderly people. Respiratory syncytial virus, RSV. This is the most common cause in very early childhood. Adenovirus, rhinovirus, rubella, varicella, and of course, the coronavirus. Okay, well, we'll talk more about coronavirus separately. Then, other than the virus and mycoplasma pneumonia, chlamydia, Coxiella burnetii, pneumocystis, very, very important. This is the pneumonia which occur in HIV people. I have taken a special extra lecture on this topic in the category of lung infection. You can see detail about pneumocystis in that particular lecture. Legionella is one more cause in the elderly people. Now, pathology. As discussed earlier, this type of pneumonia we call as atypical because it is involving the interstitium, as I told you. Typical pneumonia, which occurs in step pneumonia, which occurs inside the alveolus. That's the basic difference in the pathology. But remember, in both the places, it is the inflammation is there, but it is a site which differs, as informed you or told you in the previous slide also. Okay. So same thing, in the alveolar septal wall is atypical, and inside the alveolus is typical pneumonias. But why I showed you this slide? For this viral cytopathic effect. This is something extra. Okay, what is this? Due to viral inflammation, certain inclusion bodies or multinucleate giant cell are seen in certain types of viral infection, and that is so-called viral cytopathic effect. So the key word to be noted here are inclusion body or the multinucleate giant cells in histology in some of the viruses. Okay. Now, what is this cytopathic effect? Since it's important, let's learn more about basic concept before I really go to the main topic. So the virology about cytopathic effect. Well, cytopathic effect is also known as cytopathogenic effect. Both are same, and what we write as CPE is the short form. Okay. So what happened in this? That certain structural changes occur in the host cells. Point to be noted, the changes is occurring in the host cell, and that is being done by the viral invasion. Now, what happened in this cytopathic CPE? Lysis of the host cell. Okay, the host cell dies, and second, The cell die without lysis due to inability to reproduce. Okay. So the two things, either cell lysis or the cell will occur, or cell will die without lysis due to inability to reproduce. Of course, the cell is there, it's not able to reproduce. Again, it will die of its natural course. So there's a two thing that virus can done in any other host cell. Both these cell occur due to CPE. Okay. So point to be noted. Point to be noted in nutshell, if I have to tell you about the basic virology, not in particular in the lung anywhere, either they will break down, the cell, finish, okay, or they will not let this reproduce. The cell will lie after every cell has a normal lifespan, and after lifespan that cell will die. That means at least it will not let the cell grow. Well, again, if I have to give you day-to-day example, well, there is one person, okay, one criminal is there and he is hanged, or he is hanged. Hanging means the person dies immediately. Finish. There is another person to whom they keep in a prison. In the prison they keep, and they don't give him anything to eat, nothing to drink also, and ultimately the person will lie and he will die of starvation and dehydration, not immediately but after a few days. Well, in both the cases the criminal is dying, but here it is dying very fast, it is dying slow. Similarly, exactly same thing in cytopathic effect. Either they will do the lysis of the cell, or they will create such a situation the cell will not multiply, and ultimately it will die of the natural death. I hope you understood. With this simple day-to-day example, you could understood the basic concept about so-called cytopathic effect done by the viruses. Now, one more thing. Since most adult cells, RBCs, have I antigen, extra point, something very unique, I antigen. In the blood from a patient with mycoplasma pneumonia will hemagglutinate when cooled. So that will give rise to Coombs positive hemolytic anemia. So this will be seen only by mycoplasma pneumonia, not with other type of pneumonia. So it will lead to Coombs positive hemolytic anemia. Because they have cold antibodies. Okay. So, in atypical pneumonia, there are certain features which are common to all. They have dry cough, or so-called non-productive cough. That means not much, no sputum or not much of sputum. Sputum is minimal. That's the idea of saying dry cough. Since the airways, airspace or alveoli are not involved, that's why no sputum is getting produced. That's the reason why sputum is not there. And something very interestingly, again, this is the alveolus. Problem is in the interstitium. So when in a routine bacterial pneumonia, when we auscultate, because the problem is in the alveoli, you get crackles, you get bronchial breathing. But here, problem lies in the interstitium. That's why we don't get any clinical finding. No crackles, no bronchial breathings. So clinically, auscultation, no crackles or so-called crepitation, no bronchial breathing. So it means patient will be primarily having some symptom, dry cough, maybe tachypnea, but you auscultate, you get nothing. Then how to approach this case, that I'm going to discuss later on. So now with this background of the basic concept, now I'll be taking to you regarding individual pneumonias. The first is Legionella pneumonias. Classically, it colonizes water tank. Whenever you get a question related to water tank, or the usual thing is defective cooling system, then 99% you are dealing with Legionella pneumonia. This is the golden line to remember. That you are getting a defective, or the typical exam question is a professor went for a conference and come back and he developed some infection. So that conference, maybe defective cooling system was in the conference. So that's a classical clue to your exam question. Defective water tank is Legionella. Okay, air cooling system or defective air cooling system, whatever language they use. Okay, and usually it lead to outbreak of Legionella disease. So since it's a defective cooling system and it is not an individual cooling system, that's why it is usually because a group of people are involved, maybe sitting in the conference, just as I told you. So that is again one more indication. But in the exam, it may be the person may be always coming to you individually. It never comes in a group. So anyway, the clue is defective water cooling system is Legionella. Incubation period 2 to 10 days. Well, maybe let's say the incubation period is 7 days. If professor went for a conference, attended 1 day, come back. Okay, of course, all the professor will go to a respective place. So that's why what I said, usually individual come, although a group of people are involved together. How patient will come to you? Flu-like symptom, fever, malaise, myalgia, dry cough, dyspnea. They're always non-specific. This can happen in all types of viral infection. That is not going to give a clue that yes, it is a Legionella. But what is the most important? History of travel or attending any conference like this. You have to typical, if you are suspecting, history may give you a clue. Well, I went for the patient says I went for a conference for 2 days in that city. Okay, it was for too chilly, that something. And that you have to dig out in great detail, and then you can ask, well, do you know any of your colleague attended? Oh, yes, my colleague who attended conference is also suffering from the same. That is really going to help you in getting a clue that perhaps you are dealing with Legionella pneumonias or infection. Other features, anorexia, diarrhea, vomiting, this is especially important to be noted. They are GIT symptoms. It not necessarily that patient may come to you with respiratory system. In fact, these are more commonly involved than the respiratory system. This is not known to 99%. The point to be noted, patient may just come to you with diarrhea, vomiting, anorexia, a type of gastroenteritis type of thing. Again, a non-specific. Respiratory system may or may not be there. Oh, hepatitis, but uncommon, very uncommon. Renal failure, again uncommon. They are all rare features, but can happen in advanced cases, but very uncommon. So it means if I have to give summary, patient will come either with a flu-like symptom or a picture of gastroenteritis, simple. Investigation, well, you do the routine chest x-ray. You can see bilateral opacities. Again, non-specific, they can happen in many other conditions. Similar picture you may get in many other pneumonias. Blood test, yeah, this is going to be lymphopenia. Again, this is the one. This is a unique thing. Unique thing is not a very common thing to happen in other types of pneumonias. So if you are getting hyponatremia with lymphopenia, then at least you can get a clue that yes, we are dealing with Legionella pneumonia. Deranged liver function test can happen if the liver involvement is there, but liver involvement is not a common feature, but can happen. Urine analysis may show hematuria. Again, kidney involvement can happen, but is uncommon. Definitely, if you are getting RBC in the urine, that Legionella will never be your first diagnosis because there are n number of causes which can lead to hematuria. Okay, but it can happen. Well, confirmatory is Legionella serology or urine antigen are the one by which we can really confirm it that it is a case of Legionella infection. Now, very important point, The Legionella infection commonest organ system involved is GIT and not respiratory, the point I mentioned to you. Patient may just land up with GIT feature. Now we discussed about Legionella pneumonia. We have one more species, Legionella migdalii. It's another species of the group. It is a AFB positive organism, something unique. The unique feature is it's a Legionella, but it's a AFB positive Legionella pneumonia. The key factor was water tank and hyponatremia, two key factors which really indicate here. And it can cause infection, so-called Pittsburgh pneumonia. Additional point: Pittsburgh pneumonia is caused by Legionella, not by pneumonia, but migdalii is the one organism which is involved in this. Treatment of Legionella, we can use clarithromycin, rifampicin or fluoroquinolones. These two are the traditional antimicrobial for any pneumonias. But point to be noted, rifampicin can also be used. And just to remind you, rifampicin is a very good anti-staphylococcal agent also. Okay, and of course we know rifampicin is used for tuberculosis also. Mycoplasma pneumonia is the second organism which can lead to interstitial pneumonia. It occurs in epidemic, point to be noted. And again, flu-like symptom, dry cough, and that is a common feature in almost all type of interstitial pneumonias. But key factor is cold antibodies. This is a key factor. Only key word to remember is cold antibodies. It may occur in epidemic is the second entity that you got to remember. The two keywords. Okay. Well, one extra point for you. Infection with Mycobacterium pneumonia result in production of non-specific cold IgM antibodies. I did mention to you regarding antibodies, but they are cold antibody and they are IgM antibodies. And they react with RBCs having the I antigen. And as I told you in the very beginning also, that it is due to I antigen, antibody are there and they lead to Coombs positive hemolytic anemia. Okay. So whenever that's so commonly asked question, this line, this is the universal question. Every exam, whichever exam you write in the world, you'll be getting. If you are getting a Coombs positive hemolytic anemia, 99.9% you are dealing with mycoplasma pneumonia, and you get patchy consolidation and mycoplasma serology is the how we diagnose, but normally it is not required. If you are already getting a Coombs positive anemia, then, and moreover I tend to involve the younger age group, maybe children. So that's why it's a specific type of entity. So serology is usually not required. But if they ask you what the most confirmative test, go for serology. But what is more important is complication. Skin rash can happen. And skin rash can be erythema multiforme, Stevens-Johnson syndrome. Okay, you can see, I'll show you picture also. Meningococcal encephalitis, Guillain-Barré syndrome, Guillain-Barré or Guillain-Barré syndrome, where patient has ascending type of paraplegia. Can occur in these patients. Bullous meningitis is an ear infection in which small fluid-filled blister form on the eardrums. So in the eardrum there are some blisters are there, and this causes severe pain. Okay, so definitely the patient of this same patient of where you are thinking mycoplasma pneumonia, now he comes with a severe ear pain. Take a ENT consultation and that they will say, yes, bullous meningitis is there. Now look into this beautiful picture, eardrum, and you can see fluid-filled fluid-filled blisters are there in the eardrum. This is erythema multiforme. Okay. Classical picture of erythema multiforme. This is Steven-Johnson syndrome. All these are the complications of mycoplasma pneumonia. Well, you can see X-ray, you can see opacity. Again, that's a non-specific. But just to inform you that it can lead to this type of opacity can be there. How to treat a case? Again, this case we can treat by erythromycin, and erythromycin are the more widely used. Doxycycline can be used in the elderly people, but normally in young, very young children, tetracycline should be avoided. But you should know, yes, we can use doxycycline also. But again, I want you to highlight that this drug, erythro and cletho, which are a part of macrolide, they are the one of the primary drug to be used in any patient who is coming for OPD treatment. Chlamydia pneumonia is psittacosis, also known as parrot fever. Okay, it's a zoonotic disease. Zoonotic disease means it is the we get or human being get from any of the animals. Okay, it caused by bacteria. Involved is Chlamydophila psittaci, and incubation period is 5 to 19. So it is zoonotic. The key word is zoonotic disease, and the incubation period about 5 to 19. It is a bacterial infection by Chlamydophila psittaci. Okay. Well, the name itself suggests parrot fever or ornithosis. So it is contracted from the bird, typically parrots. Well, lovely, lovely bird to see. Also, beautiful coloration is there. Well, but that's the source. Again, it means what? This type of pneumonia, it will occur in, you have to take his professional history. Is he dealing with the birds, typically parrots? Or he has something to do with the pet, parrot are kept with the pet also. Again, history is important. So now you can see how much is the importance of the traditional teaching of history examination, so important to talk about. Again, it's a atypical pneumonia. And now, here's something unique feature is there. The patient mimics symptom like typhoid fever. So far, we discussed about whatever interstitial pneumonia, they were all flu-like feature. Flu-like is fever, pain, etc., joint pains. But here it is mimicking like typhoid, something unique. What is this? High-grade fever, joint pain, diarrhea, conjunctivitis, nosebleed. Point to be noted that these conjunctivitis, nosebleed, etc., and very high-grade fever, they are usually not seen in any type of interstitial pneumonias. Well, rose spots can be seen. Rose spots are classically seen in typhoid fever. So now you can see why they say it mimics like typhoid fever. They are also known as a Hodder spot. Look into this Hodder spot. Looking beautiful. Hodder spots are seen. They are faint, blanching, maculopapular, salmon colored. Even the rose spot that we see in typhoid or enteric fever is also have salmon color. Okay, Hodder spots. Spleen enlargement is common at the end of the first week. Well, splenomegaly is again not a common feature in usual interstitial pneumonia. Splenomegaly occurs in typhoid, and splenomegaly is occurring here also. An extrapulmonary manifestation, meningoencephalitis, endocarditis, hepatitis nephritis. Well, this is something unique which we did not find in any other type of interstitial pneumonia so far. Anyway, meningoencephalitis, etc., they can occur in mycoplasma pneumonia also. So in nutshell, if I have to conclude the thing, the key word to remember is parrot, typhoid-like fever. There are two things that you got to remember. The golden line to remember here is typhoid-like fever. Parrot. Okay. is so-called ortho parrot fever or chlamydia pneumonia infection is there. Leukopenia is a feature. Serology is non-specific, of course, right? Chest X-ray shows patchy consolidation. That's a feature. That is a feature of most of the pneumonias. Treatment again, if you look into azithromycin, that means all macrolide, quinolones and doxycycline. In fact, all these group of the drugs, what I'm talking about, one is doxycycline, they are macrolide and fluoroquinolone, where we have a levofloxacin. They're all the drugs that we use in any case of OPD case of pneumonias, viral pneumonias. The commonest cause of viral is influenza, is the most common cause. Again, picture exactly mimicking like interstitial pneumonia, flu-like fever, etc. No need to elaborate again. But one thing is there that you got to know: influenza is the most. Only one keyword that you got to remember is influenza. Other viruses that can infect are measles, CMV, varicella. Oh, coronavirus. Coronavirus is a type of interstitial pneumonia, and I'll be taking one full length talk about this, because nowadays corona epidemic going on. It needed definitely elaborate discussion I'll be taking in the next part of when I take next part of pneumonia. Well, avian influenza transmission is so-called H5N1 strain of influenza A virus. It causes serious infection in human. Mortality is 50%, very high mortality. Especially because this is often superimposed by staph infection, Staph aureus. And Staph aureus superimposing on this influenza, that case it's a deadly combination. And in case the patient has comorbidity of diabetes, then even mortality goes much more than that also. Well, here we have a treatment so-called oseltamivir is the treatment that we can give in these patients, but it should be given in the very early stage of the treatment. Then only it is effective. But if we give in the late stage, then even this becomes very effective. Certain important point that you got to know: we have a zanamivir, oseltamivir, and peramivir. All are virs. Yeah. Now, what is the basic mechanism of action? They inhibit viral neuraminidase enzyme. So they are enzyme inhibitors. And this enzyme is essential for release of virus from the infected cell and for subsequent spread throughout the respiratory tract. Okay, so these drugs, they inhibit this virus, this enzyme, and that's why the virus will not be able to release. And okay, so now what in the previous slide I mentioned, they are effective only when given in early stage of the infection. Because if you give in the early stage, the virus will not release. But once it is released, it has gone all over the body, then it becomes non-infective. I'll give you a day-to-day example for that. Suppose you are sitting somewhere and some sparking occurs. The short circuit occurs, some fire occurs. There's a beginning of sparking or beginning of fire. You can switch off the mains, you can spray some, you can use fire extinguisher, you can control the fire. Okay. But suppose things come late, when the whole building has been burned, then there is no use of using this fire extinguisher, because that time is gone. The time is gone because it was to use fire extinguisher, which is there in all the buildings. They keep it, but that can control only small fire, not the big fires. Exactly same thing when we are using this drug, we should use in the very early stage of the disease if you are suspecting Okay, but again the question comes, patient is coming when this happen in epidemic form. Patient come with the fever, sore throat, myalgia. That can happen in any viral infection. Then as a treating physician, it becomes difficult also if you are getting hundreds of patients of like this only. We don't know whether it is influenza or is a non-specific viral infection. But my idea to telling you is why they're effective only in the early stage of disease, not in the late stage. Okay, so these drugs we use for prophylaxis and the treatment of influenza, but early influenza. Aspiration pneumonia, they lead to anaerobic bacteria, play a role in aspiration pneumonia. What is this? Well, normal anaerobic bacteria, they are the part of majority of the normal oral flora. That means anaerobic bacteria are there in the normal person, in the oral cavity, or right? So, whenever aspiration occur, that means any secretion from the mouth, it enters the lung, that will carry these anaerobic bacteria into the lung, and that's the reason why we call as aspiration pneumonitis, and that's why this anaerobic bacteria will enter the lungs, because they are carrying the anaerobic bacteria. Now, what are the anaerobic bacteria? Common: Streptococcus, Bacteroides, and Fusobacterium. They are the three common anaerobic bacteria, and the mnemonic is P, B, and F. Peripheral blood film. Peripheral blood film is Streptococcus, Bacteroides, and Fusobacterium anaerobic bacteria. Now, how do you really suspect that patient has putrid fluid in the lungs, foul smelling sputum? The key word is very foul smelling, just like rotten eggs. If you are getting any question that foul smelling or the sputum has lot of smell is there like rotten eggs, then you are dealing with anaerobic bacteria. The golden line to remember. The golden line to remember is if you are getting very foul smelling sputum, may indicate anaerobic bacteria. Now, who are the patient where the aspiration can occur? Patient in stroke. Definitely stroke patient is there. He is paralyzed. He is not able to cough up. Myasthenia gravis patient, definitely the muscles are weak. He is not able to cough up, and the aspiration they tend to either swallow or something. It may go into the lungs also. Bulbar palsies, unconscious patients, especially post-ictal, means after epilepsy. Or drunk patient is totally drunk patient. Esophageal reflux disease, eclasia or GERD, gastroesophageal reflux disease, is a very important cause of aspiration pneumonia. The classical history is the patient says in this, whenever in fact GERD can lead to pneumonia, the classical history is nocturnal cough. Nocturnal cough is the one indication. It's often diagnosis is missed. So patient will say, doctor, every night I have cough, I'm not able to sleep also, whole night I get disturbed, and the day I'm normal. And nocturnal cough they talk about, one thing always keep in the mind is GERD, and of course bronchial asthma is one more, which can come just with dry cough in the initial stages. But by and large, in asthma, when the patient comes, you may get some rhonchi. Okay, but here in this, in the GERD induced aspiration, you don't get any rhonchi also. But what I want to convey the message, night cough, keep one possibility of GERD. Poor dental hygiene is, of course, the one which can be a contributory factor to type of aspiration pneumonia. Well, what it's characterized by? Acute onset dyspnea, especially if it is occurring in the setting of unconscious patient. Tachypnea is the most common feature. If aspiration is a huge amount of aspiration occur, okay, bronchospasm and cyanosis can occur, all due to huge quantity of aspiration. Okay. Now we discuss about typical pneumonia. We discuss about atypical pneumonia. We know the basic pathology in typical pneumonia. Alveolus are involved, and atypical is the interstitium is involved. So let me give you a beautiful summary. So airspace pneumonia, so-called typical pneumonias, and we have an interstitial pneumonia, so-called atypical pneumonia. Exudate in the alveoli and consolidation. Of course, this is typically we talk about pneumonia, lobar pneumonia, and of course, small consolidation will occur in bronchopneumonia. No exudate in the alveoli. Alveoli are air filled. Since they contain air, so no consolidation, and infiltration occurs in the interstitium. Here, the infiltration occurs in the alveoli. And here, in typical bacterial pneumonia, it is usually neutrophils which infiltrate the alveoli. In case of interstitial, it is mainly lymphocyte. Agents responsible are extracellular, and they are intracellular. Majority of the organisms, they are inside the cell. I gave you example of virus, which have a viral cytopathic effect also. And why? The virus is intracellular. That's why it is going to cause lysis or can cause arrest of the multiplication. They're all intracellular. Cough is productive of purulent sputum is a dry cough. The reason I already mentioned to you. Any pathology in the alveoli, they contain lot of exudate that comes out. Finally, it goes a alveolar pattern of chest X-ray, and here the interstitial so-called air spaces are empty. Typically you get interstitial type of pattern is there. Well, lung abscess is in continuation to pneumonias. It occurs in large volume aspiration. Definitely, we can say that it may be a continuation of the aspiration pneumonia. Okay, usually with poor dentition. So now you know the importance of any case of pneumonia come to you. You have to not only you have to look into the chest, you have to look into dentition also. Okay, dental, if they are very unhealthy dental, don't forget to take any dental consultation. He might be having some dental problem also, which we as a physician may not be able to look into that problem. So, but at least you understood the importance of dental hygiene for a patient who has come with a pneumonia. So now, as I told you, the large volume aspiration occurs in patient of stroke, seizure, intoxication, endotracheal intubation. Is the extra thing which I have mentioned here. Okay, ultimately, whatever reason lungs has been infected. So now these patients, they tend to develop chronic infection over several weeks with large volume sputum. Point to be noted, when I said about aspiration pneumonias, they tend to occur, it may come even in the acute manifestation, they may even come, the bronchospasm is there. But here, when the talk of lung abscess is a chronic, it doesn't develop overnight. Okay, and large volume of sputum will be there, and of course, no need to say, it will be usually very foul smelling. Okay, foul smelling sputum because of anaerobes. Since it's a chronic problem, weight loss may be there, and clubbing can be there. Point to be noted, so far we discussed in all the pneumonias, the clubbing entity was not seen anywhere so far. So a unique thing, now you can make out everything as a unique. If they talk about hyponatremia, then it is Legionella. If they are talking about Coombs positive hemolytic anemia, it is mycoplasma. If they are talking foul smelling sputum with the clubbing, it's anaerobic lung abscess. Why can't we anaerobic pneumonia? Clubbing never develop overnight. It takes long time, right? So again, clubbing means some chronic, usually chronic problem is there. Of course, sometimes clubbing can be congenital also. Anyway, in the disease, it's a chronic. It's seen in chronic disease, not in acute. How we diagnose the case of lung abscess? Chest X-ray is the best initial test. In fact, for every lung pathology, by and large, the first investigation is always chest X-ray, which I always say. Any cardiac problem, the first investigation is always ECG. Yeah? So it may show a cavity, possibly with air fluid level. This is important. Cavity with air fluid level in chest X-ray is 99% is lung abscess. CT scan will definitely accurate better than chest X-ray. That is universal true. And lung biopsy is the most accurate test, and it can give you a specific biological, microbiological diagnosis also. Okay. So friends, in this, the key word that you got to remember is air fluid level in a cavity. Sputum culture is now something unique. Sputum culture is not the accurate test. Why? Because if you go for sputum, already in our flora, it's a normal microbial is there. So this one infection, usually in all infective pathology, culture is one of the diagnostic feature. But this is one exception where sputum culture has no meaning, because already we have anaerobic bacteria in our oral cavity. Well, beautiful picture. You cannot miss this picture. Okay. Just see state level. Look, this beautiful picture. Cannot. If you remember this picture, you will never forget in the exam. I can remove it also. Yeah, you can see it. You will never forget in the exam. Lovely picture, so-called fluid-filled cavities there. Treatment is clindamycin or penicillin are the best to cover lung abscess, because they are called by anaerobic bacteria, and these two antibiotics, they work very well in this anaerobic bacteria. A quick recap of the last minute revision point. Cause of atypical pneumonia: mycoplasma pneumonia, viral, chlamydia, coxiella, pneumocystic, legionella. They have dry cough and they involve the interstitial space. Legionella pneumonia is water tanks, and mycoplasma is autoimmune hemolytic anemia. Chlamydia pneumonia, psittacosis, Hodder spot, lung abscess, chest X-ray, the best initial test, and you get fluid-filled cavity. Well, now we'll talk about how to investigate a case of pneumonia. The best initial test is chest X-ray. But remember, the first chest X-ray may be false negative in 10 to 20% cases. What is the meaning of this? Let's discuss this. Let's correlate medicine with radiology. Well, it is true that in the initial stages that opacity doesn't appear, although inflammation is there, infection is there. So when you do X-ray, you may find normal X-ray. So normal X-ray doesn't rule out pneumonia. At the same time, when you have treated the patient has become perfectly all right, no symptom, cough has disappeared, but still opacity may persist for some time. Okay, that means persistence of opacity doesn't mean that patient is not has been cured. So what we learned in the initial stages, patient has pneumonia, but no chest X-ray normal. And in the later stage after treatment, patient has no pneumonia, but still opacity is there. Okay, so that you can say in the initial stage it is a false negative can be there, in the later stage there can be false positive. Well, now you want to determine the specific etiology. Okay, what is the reason which organism has caused, and especially bacterial etiology. Sputum, gram stain and culture is the single best to know about what is the reason, which bacteria is involved in particular. But it is positive only in 50% cases. It may or may not be positive. While sputum gram stain is adequate if there are more than 25 WBCs and less than 10 epithelial cell. This is a very interesting finding, that unless the sputum is adequate, but what are the criteria of adequacy? At least minimum 25 WBC should be there, and the epithelial cell should be less than 10. Now we have been talking about atypical pneumonia. Now lab wise, what is the reason or what is the meaning of atypical? So it is caused by infection by those organisms which are not detectable by gram stain, and they are not culturable or standard blood agar. Why they are not detectable gram stain? That we know. There is no sputum at all. Alright, even some little bit of sputum is there. Even you try to culture in standard blood agar, you will grow nothing. That's another one more lab criteria by which we can say what do you mean by atypical pneumonia. Although we have seen previously, we have seen the comparison also between typical and atypical pneumonias. Well, raise TLC and increase ESR, of course, they are very important finding, but non-specific. But I will definitely like to say if the TLC count is low, that leukopenia is there, that is a very bad sign. Remember, leukopenia in a case of pneumonia with hypothermia, there are the two important findings which indicate the patient is going into septic shock. That means we have to monitor the patient very careful by checking the BP and other clinical parameters. Well, now we talked about sputum culture. Now we talk about blood culture. Is there only in 15% cases of CAP is community acquired pneumonia. But we definitely send blood culture in all the cases, although positivity is very less. Chest CT scan and MRI, definitely they give a better definition. That is true for almost all the lung finding, whether it is tumor, whether it's pneumonia or interstitial lung disease, whatever it may be. Definitely CT has a much better finding as compared to chest X-ray. Now there are certain cases where we have to do some additional tests, especially in severe disease with unclear etiology, okay, or non-responding to treatment. We are giving treatment but patient not responding, or we are not sure about the etiology, then we like to do some extra tests. Bronchoscopy. Although we rarely need it in community acquired pneumonia. We don't do. In fact, it's not needed. But again, as I told you that in special situation we like to do. So, okay. So it is done as usual, severe worsening cases, nothing we are getting in blood culture, gram, all sputum investigation and blood test is negative, we are not getting, then you like to go for bronchoalveolar lavage, provided patient not responding to your treatment. But one thing is very sure, pneumocystic pneumonia is only diagnosed by bronchoscopy. So I can make your subject very easy, at least bronchoscopy is for pneumocystis, no doubt about it, because there is no other way, better way of diagnosing pneumocystic. Thoracentesis, the pleural effusion is there, then we can go for aspiration of the pleural fluid, and you can look for the cytology and biochemistry. So in this particular slide, there are two things to remember: pneumocystis and if pleural effusion, then we can go for pleural aspiration, two keywords. Now, what are the complications that can occur in a case of pneumonia? Respiratory failure. Well, it is usually type 1 failure. Okay, it's very common. But in the advanced cases, we may have type 2 failure. We are all well aware in type 1 failure, PaO2 is less than 60 millimeter mercury. And PaCO2 is less than 40 millimeter mercury. But in type 2, we have hypoxia. PaO2 is less than 60, but PaCO2 is more than 45 millimeter mercury. So that means hypoxia is there in both the condition, but in type 2 we have a hypercarbia also, type 1 a hypocarbia. But remember, this is the usual finding. This is a late finding. So now that means the terminal case. That means even when you have done ABG, you can come to know whether you are dealing with the acute case or in the terminally ill patient. Hypotension. This can be due to dehydration. Well, these patients have a lot of vomiting or maybe having dehydration, and maybe vasodilatation which is a feature of septic shock. Okay, so as I mentioned in the previous slide also, low BP is a bad sign that maybe indicates septic shock, but don't forget it may be due to dehydration also. So you have given a fluid challenge. You give fluid. If the BP comes up, in BP increases, that was due to dehydration. But you have given some fluid challenge, but BP still remain low, then perhaps this is due to vasodilatation. This is a very, very important point which can differentiate whether it is dehydration or due to vasodilatation is there. Pleural effusion is again a common problem that can happen in case of any pneumonia. So as of now, the three keywords are respiratory failure, hypotension, and the pleural effusion. Pneumothorax, this classically more common to occur in Staph aureus and pneumocystis. They are the two well-known organisms which can create pneumothorax. Empyema is the collection of pus in the pleural space. It is usually unilateral. Okay, and bacterial pneumonia are the most common cause of pus in the pleural space. Lung abscess that we discussed, very common in anaerobic bacteria. And the classically what we read already, that patient will be having very foul smelling sputum will be there. So the keyword are pneumothorax, empyema, and lung abscess. There are three keywords that you got to remember in this particular slide. Well, now we come to some extra things. We discuss about the local problem. Now atrial fibrillation, quite common, especially in the elderly person. Well, that can really, if the patient may just end up with atrial fibrillation, it will really become difficult for a treating physician to whether it's due to cardiac condition or maybe due to other condition, especially in the elderly person. AF develop, everybody will think about certain cardiac problem, but do remember this can occur due to non-cardiac condition also, and don't forget this can, in an elderly person, this may be the only manifestation of thyrotoxicosis. Okay, so we have to keep in this mind regarding lung condition, thyroid condition, and cardiac condition. Pericarditis and myocarditis can complicate. Well, pneumonia is there, especially on the left side. Infection can go to the pericardium also or myocardium. The patient can have additional problem. Jaundice, mainly due to it is type of cholestasis type of jaundice. This is due to sepsis. Well, septicemia is there in the body that can very well lead to involvement of the liver, can lead to jaundice, or secondary to even antibiotic therapy also. This is the point you have to keep in mind. Which antibiotic which we usually use in pneumonia can lead to jaundice? Flucloxacin and co-amoxiclavulinic acid are the two things. Amoxiclavulinic acid and flucloxacin. So remember, the key word is jaundice, and sepsis or drug, both can, either way this can be there. Meningitis, well, infection can go to distance. As a matter of distance infection is there, it can involve the meningitis. And septicemia, septic shock, the point I already mentioned. Well, one of the important clinical criteria about septic shock is systolic BP below 90 is usual millimeter of mercury, the usual clinical criteria that is taken as a case of septic shock. Simple, even a nurse can check the BP and can inform you that the BP is, systolic BP is 80 or 70. That means it should immediately alert you, and including, don't forget temperature also. the two things which a staff nurse can check and inform you, and if the lab report has come, TLC count is low TLC count and low temperature, low BP, they are the one which really indicate that a patient is in septic shock. Okay. Well, very important feature is curve 65 score. This is the universal question. It is used to assess severity of pneumonia. Note it down very carefully. Well, patient has come to you. How severe is the patient? What is your line of treatment? It should be OPD treatment, or it should be hospitalized or hospitalized in the ICU. You need to have certain guidelines, and for that, curve 65 score has been given. What is this? Well, there are certain features and each one is given 1 point. Note it down. Now, what are the points? First is confusion. Remember, elderly people may just come with confusion only. The patient is confused, we give 1 mark. If no, then give 0. Then blood urea more than 7 millimole per liter. And again, for those who are using milligram percent, from 7 millimole you multiply by 2.8, 19.6 milligram percent. So both way I have given the values. Okay. That means increased blood urea is again a criteria. This is CU. R is respiratory rate more than 30 per minute. That you can count very easily. R. B for systolic BP below 90 and or below 60 is diastolic. Okay. So if the diastolic is below 60, but definitely we can use both, but this has got much more weightage as compared to diastole. But as per theoretical thing, both can be used. The patient, even diastolic, low diastolic BP is again a criteria, which is a part of B. 65 age above 65 years. That means elderly people are more likely to have a more severe type of pneumonia. And again reminding you, elderly people above 65 may just come with confusion. Other parameter may be normal. So of course, elderly men coming with confusion, again it becomes a huge differential diagnosis. Okay, and not to forget, hypoglycemia is again a very common feature to cause altered sensorium in an elderly person. But wide variety, and that become the physician job tougher, because we don't have clear-cut idea if the patient, elderly patient coming only with confusion with no other such parameter. But do keep in the mind, curve 65 score. So we have 5 criteria. That means 5 marks, 1 number each. Let us see how we do scoring. So patient has 0 to 1 score. You give home treatment. Why? They have a low risk, mortality rate is less than 3%. 2 intermediate risk, mortality is 3 to 15, and 3 to 5 severe high risk, mortality rate may be much more than the 15%. So now you understood the applied, clinical applied, the use of so-called curve 65 score. So you calculate the score and you decide how much score is there. Now you have your job has been made much easy. 0 to 1, OPD, 2 hospital, and more than 3 to 5 is this need ICU treatment, this need hospital treatment, and this need OPD treatment. So you got to know the mortality rate as well as where and how to treat the patient, because treatment differ in all the 3 conditions. Other feature which increase the risk of the death are coexisting disease. Diabetes is the most notorious thing, which really, and diabetes is very common. An elderly person with a diabetic patient, it has got a very high mortality. But don't forget, hypoglycemia can manifest as confusion. So in that case, treat hypoglycemia. PaO2 less than 60, that means the patient is in the respiratory failure. Again, a dangerous sign. Bilateral multilobar involvement, again a bad sign, and this is especially very common in a patient of COVID. And oxygen saturation less than 92%. All these are additional factor which are really bad sign, and if they are there, although they are not the part of curve 65 score, but they really give additional value that patient should be taken into hospital. Such patient, especially this patient, these three patients should not be treated on OPD basis. They should be better hospitalized, because in such cases mortality is very high. Well, again, hypoxia and hypotension are the two most important reasons of hospitalization, the same what I was telling you in the previous slide. Now, how to treat a case of pneumonia? So we are clear about it. OPD treatment, you are sitting in the OPD, patient comes to you, you diagnose pneumonia, you can give macrolide, azithromycin or clarithromycin. Okay. You can give doxycycline also, or respiratory fluoroquinolone, levofloxacin or moxifloxacin. Well, additional point, these drugs should be given empty stomach. This also should be given empty stomach, and that hamper because if you give with the food, after food, the food hampers the absorption of these drugs. And at times, this is not known to a good percentage of people. The treating doctor are not aware of this point, especially at times youngsters are not aware. So in that case, you keep on treating, patient doesn't respond to the treatment. Problem is not in the treatment. The problem is not in the organism, but in the way that it was given. Simple thing, simple basic pharmacology. These drugs should be given empty stomach, including rifampicin. That is well known to all the doctors. But these are the things. As far as these fluoroquinolones are concerned, that you can give after meals also. But one of the very common side effect of this drug is skin rash. Skin rash is seen in good percentage of cases who are being treated with fluoroquinolone. Okay. Now, hospital-acquired pneumonia, we know that within 48 hours, after 48 hours of admission and up to 90 days of discharge, the patient develops pneumonia we call as hospital-acquired pneumonia. This is usually by gram-negative bacteria. Hence, in these patients, macrolide are not effective. Remember, macrolide is a very, very important drug to be used in OPD treatment. Now, the organism has changed. Of course, one more organism which is there, which is the cause of hospital-acquired pneumonia, is staph pneumonia. But staph pneumonia itself is a very dangerous bacteria, okay, because it can lead to very severe, very rapid mortality, especially in the setting of influenza. So although macrolide can be effective against staph, but still it's a very dangerous bacteria. So we don't want to take a chance. We like to give injectable treatment, not the oral treatment. So what we can give, we have to give drugs, because one more organism which is a common organism to cause hospital-acquired pneumonia is Pseudomonas also. So we want to give anti-Pseudomonas antibiotic. Remember, now there is no role of macrolides. So we can give cefepime or ceftazidime. We can give anti-Pseudomonas benzene piperacin plus tazobactam. Okay. Carbapenem, imipenem, meropenem and doripenem are the one which we can use. Okay. So we can use, provided, remember they are going to cover gram-negative as well as staphylococcal infection also. So again, in hospital-acquired pneumonia, we don't treat by oral tablets. No way. We can't take the risk at all. Now we have one more special situation, so-called ventilator-associated pneumonia, VAT. It is 5% per day. Oh, huge percentage. What do you mean by this? Patient has been intubated. He is on ventilator, and they can develop lot of inflammation in the lung parenchyma, so-called 5% per day. So that may produce a lot of problems. So let us see why they develop. Decreased clearance by mucociliary mechanism. It is a very important condition which predisposes to pneumonia. What the clinical applied? So here lies anybody who is on ventilator or intubated. It is a duty of the treating physician and the resident doctor on duty go for regular aspiration. Okay, use aspiration, suck out the whole secretion. Simple. Simple is a just, you can say you are clearing the secretion in the endotracheal tube, and that is going to save lot of problem. Simple. And that is, and remember, at time these mucus can even make a plug, and that can even make the ventilation very ineffective. So regular cleca aspiration by suction machine is essential to take care of this problem. Bacterial colonization, especially when the stasis of the secretion is there, then bacteria grow. But if you make the suction, then you can avoid this problem also. What are the features? How do you really know that patient on ventilator has got pneumonia? Fever, more fever, higher temperature, rising TLC. TLC is going higher and higher. Today the TLC was 12,000, next day goes to 14,000, next day go to 18,000. You see the TLC report for the last few days, it is rising. You are going for VAT. New infiltrate on chest X-ray, and purulent secretion coming out of the endotracheal tube. ET tube is endotracheal tube. So they are the few parameters by which we can really say that patient has developed ventilator associated pneumonia. What test we do? Sputum culture from ET tube is useless. This is not known to 99%. Classically, what they did, they put a tube and they take secretion from the endotracheal tube. No way. It's useless. Now come the gold medal question. Tracheal aspirate by catheter below the tip of endotracheal tube is better. You go via tracheal. Simple, putting a needle, not a very dangerous thing, but need expertise beyond doubt. Okay, but there is one more. Suppose you don't want to take a chance, you don't want to go via tracheal route, then go for bronchoalveolar lavage. Then again you are going to ask me a question. Just now you told don't take for endotracheal tube, but there is a trick. What is that? Bronchoscope placed below the lower end of endotracheal tube. What do you mean by this? Well, this is the, suppose the endotracheal tube is there. Okay, let's say, and usually this lower end is slanting. You put a bronchoscope like this. It goes, take, and you come, yeah. So you come out of the lower end of the endotracheal tube. Now below that, now you can take aspiration. This you can use. But if you take any aspiration from somewhere here, it is of no use. So the aspiration should be taken from the lower end of endotracheal tube. Okay, if not, well, there are other video assisted thoracoscopy, but not a very common investigation. Open lung biopsy, the most accurate but risky, usually not done. Okay, so but it's my duty to tell you what to do, what not to do, and how much risk is there. So before I really go, some of you youngsters may not have seen the endotracheal tube. This is a tube they put when they had to put the patient on ventilator. It's like that only. Okay, we have a cuff, they inflate so that its stability is there. So this, the lower end is beveled. Beveled means it is oblique. Okay. So what I am talking to you, that you want to take a aspiration. You put the bronchoscope, it will go, and you have crossed here. So you have crossed the lower end of the endotracheal tube, you cross it, and then only you can take aspiration. This is a much better picture to really show if this the patient in actual. So again use like this and go up to, yeah, this. Okay. So this is how you are going to collect the secretion from the below the lower end of endotracheal tube. So now in such cases, well, we treated the hospital acquired pneumonia. We had 3 antibiotics, but we gave only 1. But here we give 3 antibiotics. Point to be noted. Give 3 antibiotic, anti-pseudomonal beta-lactam. List I gave to you. Plus anti-pseudomonal fluoroquinolone like Cipro or levofloxacin. Plus methicillin-resistant anti-staphylococcal vancomycin or linezolid. In that way, they have practically covered up everything. They have covered Pseudomonas, gram-negative bacilli, Staphylococcus, gram-positive Streptococcus, whatever it may be. With this broad spectrum, by and large, they have covered majority of the bacterial infection has been covered by these three antibiotics. Now, what are the indications of pneumococcal vaccination? Who are the patients who should be strongly advised to take pneumococcal vaccine? All people above 65 years, okay, and they should have this vaccination. Cardiac patient, renal patient, and lung patient, they should take vaccination. They should be given. Splenectomy patient, mandatory, because these patients are prone to this infection. Sickle cell anemia, the reason because it lead to splenectomy, so all sickle cell patients should get pneumococcal vaccine. Blood cancer people should get. Out of all these are the two most important. Of course, other are important, but they are two most important where vaccination is compulsory. Immunosuppressed patients should given like diabetes, HIV, alcoholism, CSF leak, and cochlear implant. These are immunosuppressed, and they are the other patient who should give a pneumococcal vaccination. But something is very interesting, is it essential for a health worker to take pneumococcal vaccination? The answer is not absolute. But these are the people who we should give health worker. As such, what the recommendation is that it's not absolutely necessary. Okay. Well, a quick recap of the last minute revision point: complication pneumonia, respiratory failure, hypotension, pleural effusion, empyema, and lung abscess. Atrial fibrillation, pericarditis, jaundice, meningitis, septicemia, septic shock. Curve 65 is a score to assess the severity of the disease. Treatment OPD is macrolide. In hospital-acquired pneumonia, anti-Pseudomonas, and ventilator-associated, we give 3 antibiotics, covering almost all the gram-positive, gram-negative, and Pseudomonas. We are covering it. Thank you very much. God bless all of you.